I just did. So, hey
Oh,
everybody,
okay. Are you okay? You want to give a formal introduction?
I
Uh,
am.
okay.
I'm Roxanne Davenport, and this is Seizure the Day with Lorna Myers. And I also have Dr. John Bennett and Dr. Downs on here with me today. And that's
From your field, and he went to medical school, and he's now.
Yeah, yeah. So should we introduce ourselves, each one of us, or how do you want to
go
do
right
this?
ahead. Sure.
Yeah, okay. So I'll introduce myself. I'm Dr. Lorna Myers. I'm the director of the Psychogenic Non-Epileptic Seizures program at the Northeast Regional Epilepsy Group in New York and New Jersey. And I think I've been invited here today to speak more about psychogenic non-epileptic seizures, but obviously I've also worked in the world of epilepsy for over 20 years. So, I tend to see mainly patients with psychogenic non-epileptic seizures, which is abbreviated PNES, but also a number of patients with epilepsy as well. Um, yeah.
Okay,
Yeah.
Simon, you want to introduce yourself?
Hello, everyone. My name is Simon Downs, co-producer at neurosurgical.tv mainly. I'm a developmental psychologist from Japan. Graduated in 2002. I was a psychologist there for about 20 years. School-based psychologist in a bilingual immersion program in Tokyo, and my postdoc work was done on autism, Asperger's syndrome specifically. Um, uh, Raising self-esteem through group activities, home activities, etc. And then following that, I went to medical school. 10 years later, graduated. So that was very recently. So now I'm thinking about what am I going to do the next step. So that's where I am at. It's very nice to meet you all.
Very
Nice
good.
to
And
meet
he's
you.
an unpaid employee of Neurosurgical
That's right.
TV. Let me mention that. I'm John Bennett, the creator of Neurosurgical TV. I ran into Roxanne online. She was doing various webcasts, and I like her idea of trying to have a patient group aimed at patients, not necessarily doctors all the time, occasionally like today,
Mhm.
but for patients to come to see what's out there. And I look forward to having Roxanne do more. Thank you.
Thank you.
Yeah,
Yeah,
wonderful.
I've got a lot of questions that to explain or let you explain what the neuropsychological epilepsy actually, I mean, how with it going along with anxiety, and it can be just about the same as with regular epilepsy, which with depression and no sleep, and you
Yeah,
just
yeah. I
people
think it,
have.
PNES, it's tricky, right? Because they look so much alike, um, look a lot like epileptic seizures. And so that's what leads to those mistakes, right? Those misdiagnoses sometimes. Um, you had an experience like that, right? With a misdiagnosis, and then and the reaction. I think it's very hard also to understand what this diagnosis is, especially when you've lived with epilepsy for many years, right? To then have this thrown in there. Yeah, yeah. Um, so
So do you
yeah,
want to give a formal presentation of your topic, and then we can do what Roxanne wants to do?
sure. Yeah. So we can start out just by defining what PNES is. And I should start saying that the other thing is PNES has a lot of different names. There are a lot of bands of clinicians or scientists who are sort of like, on one side or the other. I'll say that initially, historically, PNES used to be called hysteria. So this is what Sigmund Freud, and all those people back then, Charcot and etc., were studying and treating. And some of those famous Freudian cases had what he called hysteria. which would now be considered psychogenic disorder. So it would be considered a conversion disorder, right? That, sometimes it's called conversion disorder. More recently, this is also called functional neurological disorder. Um, so that's historically. And then there was a slight improvement, but not really. So we went from hysteria to pseudo seizure. And pseudo seizure, the problem with that is that pseudo is sort of fake. I mean, it means fake. And it's used in medicine and it's not used in a pejorative way for a lot of other disorders. But with pseudo seizure, there was a tendency that uh, health professionals and the general public would sort of see these patients as they are making this up. This is fake. So then there was the next move to change the name, and that's where psychogenic non-epileptic seizures came up. And that was a whole group of people who got together, experts in the field, and they decided that it was really descriptive, right, to call it psychogenic because it was coming from a psychological origin, non-epileptic because they are non-epileptic, and seizures because they look a lot like seizures. It can be almost impossible. Even a seasoned epileptologist sometimes has trouble just seeing them, knowing if they're one thing or another. So that was the big improvement. And now there's another group of people who are wanting to change the name yet again to functional seizures or functional dissociative seizures. I know it becomes, I see your face. It just becomes like a whole bunch of different names. There are reasons for why they want to call them functional, and that's partly because these seizures are not only brought on by emotional or psychological triggers, although that's the majority of them. But what we now know is that patients with these seizures tend to have sort of a physiological hypersensitivity. So sometimes either not sleeping or running around all day without resting or not eating enough that day, not having enough fluids, being out in the heat. I had this one patient once who had been up on his roof, sort of changing his roof for 5 hours or something like that. And it was very, very hot. And so then that led to a seizure later on. So it's primarily psychogenic, but there are also some physiological triggers to these seizures as well. And so that's why there's this movement to change the name to functional seizures or functional dissociative seizures. It's basically, I mean, if we try to think about what are these PNES, right? And I'm going to call them PNES. So we just come up with one abbreviation and let's stick with that. But what they're brought about is the best way I can explain it is it's sort of like a brain network disorder. So there's nothing that you will visibly see that is wrong with the brain, but there is a tendency, we could almost say the amygdala, maybe if we were able to see that, and I think there have been some studies that showed that there was some difference in how parts of the brain function compared to other people. The amygdala seems to be on high alert. That, for whatever reason, then communicates, we could say, to the motor area, which causes these seizures. And what you need to do to treat them is to engage the prefrontal cortex to bring in your thinking and to say, okay, let's try deep breathing, let's do grounding, let's figure out what triggered this. Maybe it was an argument I had with my mom yesterday. Maybe it was that I went all day on the roof, without this, that, and the other. And so then you make certain changes. And when you do that, and you do it sort of regularly, and you do a lot of self-care, you start to see that the seizures get better. Okay. So they're really, yeah, go ahead.
Well, I understand all that because being lucky to have an aura, I would know when they would come on, and I'd try to put my mind on something else and try to calm down. It's just I never thought about counting though. And when I was reading more about it, counting back from 100 or up to 100, something like never thought about a number. And here, I love math and I'm quick at math. You'd think I would remember to count for them, but I would always try to think of something else that
And you
just
would
get my
find that
mind off
sometimes
of
it
it.
would help. It would help
Yeah,
sometimes to
yeah.
figure
If like I
any math.
didn't have my magnet on
Uh-huh.
my arm,
Yeah,
could swipe over
mhm,
my vagal nerve stimulator.
yeah.
I would try talk myself out of them, and it helped a lot.
Mhm,
A
mhm.
lot of them I've taught myself out
Yeah,
of, and I guess that's why they thought
yeah,
mine could be. I still
yeah,
say psychological, but
yeah, yeah. Well, but there's a stress component in epilepsy as well.
Mhm.
And sometimes just the fear, that I'm about to have a seizure, I feel that a seizure is coming on. Maybe, what you're doing is you're bringing that down. You're distracting yourself. You're focusing
Yeah,
on the counting or whatever, and so then that anxiety, is coming down as well. Yeah.
that's hopefully, yeah, talking to other people could pass that on to think of counting because that
Yeah.
definitely takes your mind off of
Yeah.
everything.
Yeah. Yeah. Counting, sometimes, naming certain objects in the room. So you pick maybe four objects, five objects in the room, and you just name them, and then you name them again. So you're really sort of focusing in on these things that are, in the here and now. Um, Other things are, for example, with non-epileptic seizures, grounding techniques like holding an ice pack because it's cold and it's sort of like brings your
Okay.
attention to that cold sensation, or maybe holding the ice pack but also transferring it from one hand to another. So that can also help. Yeah, yeah. And deep breathing is a really helpful tool for non-epileptic seizures as well. I mean, for a lot of things. I mean, we should all be doing deep breathing, but especially with PNES, it helps to regulate emotionally, physically, and so then it can be really helpful for the seizures too. Yeah.
You're bringing up a lot of great thoughts and ideas for patients, that really need thinking, well, why am I? They haven't been diagnosed.
Mhm.
And with that, maybe they could try it.
Yeah.
You know,
Yeah.
something
There's
always.
a in the chat. There's a this non-epilepticseizures.com. That's an information website that has all sorts of frequently asked questions about non-epileptic seizures. And so sometimes that's useful if someone's not sure. They can go in and read some of those questions and see, does this sort of make sense with what's happening to me or not, right? Again, it's just some information and then it's got to be discussed with your physician. But sometimes physicians haven't thought of PNES as a possibility. And I've had some patients who brought it up and then they eventually ended up changing the diagnosis. It was actually, the right diagnosis. So patients doing their own research and bringing stuff up to doctors or asking questions sometimes goes a really long way. Um, yeah.
No, I have a question, and I may have missed it. I guess the treatment is different for non-epileptic than it would be for epileptic, right?
Yes. Yes.
What
Very.
is the treatment now considered to be the best treatment for non-epileptic? Is there a treatment
Yes.
like that?
Yeah.
What is
There
the
is. Yeah.
treatment
Thank
now?
you. Thank you for asking that. Yeah. We're in a very different place than we were maybe 20 something years ago. 20 something years ago, there was really no treatment for non-epileptic seizures. Typically, a patient would be diagnosed and they were told, you need to see psych, you need to see psychiatry, and they would sort of send them out the door.
Right,
Um,
just to get
and the
rid of them,
psychi-
just to get rid of
yeah,
them.
and the psychiatrist didn't know what to do with them because there was no research on specific treatment types.
Right.
So they would usually try to do the usual, and then the patient would have a seizure in the office, and so then they would send them back to neurology because they would say, this looks like epilepsy. I think you've made a mistake. Now we're in such a better place. It's like the renaissance of PNES. There are at least three, four different types of treatments that have been reported on, that some have had randomized controlled trials run for them. So the most well-known is cognitive behavioral therapy. And all the treatments, by the way, are psychotherapy, but they are not
Okay,
just your run-of-the-mill.
no surgical.
No surgical, no.
Okay.
And they're not your run-of-the-mill psychotherapy. They are psychotherapy that is tailored to treat the seizures. The most well-known is CBT, but it's CBT that has been redesigned to actually focus in on the seizures. For example, the patient will be keeping a seizure log. The patient will be learning certain relaxation tools. Will be seeing how they think and how they behave. Other treatments that are out there, mindfulness-based treatment for PNES. There's also something called prolonged exposure treatment for patients who have PNES and PTSD, post-traumatic stress disorder. And then there are some other group therapies that have been researched and reported on. There's psychodynamic therapy that was also reported on. So there's a lot out there right now, and some manualized treatments. That's the other
So
thing.
they're all proven and they're all accepted.
For the most part, CBT has had the best, sort of randomization, control, and this and the other. Prolonged exposure. I've been doing this. We've been doing it in our group, and so our study ran from 2020 March, COVID, to 2025 March. Like we're finishing now. The study was supposed to be in person, comparing two different types of treatments. One was a trauma focus, one was something else. We had to resubmit everything to the IRB, obviously, because lockdown. So the whole study, really went through a lot. And we're just finishing now. Next week is our last, two patients who are having their 12-month follow-up. Yeah. So that's going to be coming out soon as well. Yeah.
Okay, I see that Simon has a question.
Just looking at the Cleveland Clinic definition of it, and it's quite full. I must admit I didn't know
The
about it.
definition of
Is it-
non-epileptic. Can you share it, Doug? Can you show us?
Yeah.
Can you
I'll have to,
share it on the?
I'll have to look for
Can you
it.
share?
I'm looking on my smartphone, but yeah, 1 second.
We've come a long way.
Yeah,
Where
there's a
it
lot of
used to
information
be
about it.
hysteria, conversion of emotion into physical, which actually, I mean, it's sort of, in some sense, it does happen. But now with an understanding of, neuroanatomy and how, I guess from the neurosciences, we're understanding much better how this can actually develop and how you can develop something that looks so much like seizures, that looks like epileptic seizures, but is not. So did you share? Oh, here it is. Okay. Let me see if I can open it.
Wondering, how do you feel about the definition and the treatment and prognosis that the Cleveland Clinic offers?
So if it's okay, I'll just read some of it out loud. It says PNES involves attacks that resemble epilepsy-related seizures in symptoms and signs, but abnormal electrical activity in the brain does not cause them. And that's actually one of the reasons that the gold standard diagnosis is video EEG monitoring, because they do have to be able to see that there's no abnormal electrical activity during the seizure. So instead, the seizures are a physical reaction to underlying psychological stress. Could be, but I also think that, actually it's a psychological distress, sorry. It is to psychological distress, but also there are these physiological sort of, triggers as well that I think have to be considered. It says the psychiatric diagnosis for PNES is a conversion disorder, as a mental stress is being converted into a physical symptom. Conversion disorder, also known as functional neurological symptom disorder. Yeah, a lot of the stuff we were just talking about. And many people with PNES have experienced trauma, and that's true, psychological trauma. People who have PNES are not faking the seizures. They have no conscious or voluntary control over them. Many people with PNES first receive a misdiagnosis of epilepsy. It's also possible for someone to have PNES and epilepsy-related seizures. And that happens in around 10 to 15% of cases. Yeah, all of that spot on. and other names: psychogenic non-epileptic spells, psychogenic non-epileptic episodes, psychogenic non-epileptic attacks. And now, like I mentioned, this probably needs to be updated: functional seizures or functional dissociative seizures. And then, so I think a lot of it, this looks very accurate. This is actually a good place to go for information.
Well, Mr. Musk has been in the news a lot, and
Yeah.
many things he's doing is implants. Is there anything about implants in epilepsy as far as from the neurosurgical point of view? Does implants have a place in the treatment of epilepsy? Do you
Well, with
know?
epilepsy, it very well could. I know that now there are these brain pacemakers, right, that are being used. I'm trying to think, what is the name? I'm blanking. Neuropace. Neuropace, I think, is one of them.
Okay.
Um, and
Neuropace is the name of the
of the
procedure?
company, I think,
Oh,
that
okay.
produces these little implantable pacemakers.
For,
They're used for epilepsy.
it's
Um,
just used on a PRN basis when a person has a seizure. When they have a seizure,
um,
the implant kind of,
well,
I
I
don't
think
know.
that they
I don't know how it works.
they have to do they do a lot of studies to
Okay.
be sure that that's going to be the right course of action. They have to do not only MRIs and specs, and they also now are doing MEGs, and they're doing all sorts of the pre-surgical conferences and all of that. They all get together, they look at all the testing, and then they would decide if that's the right approach. Instead of a resection, instead of a vagus nerve stimulator, instead of whatever else, medications and so forth. But yeah, that's something that is being used now in epilepsy. Now for PNES though, there is no surgery, and I don't think that there will be in any time in the near future, because most cases respond well to psychotherapy. Around 80% respond really well to psychotherapy. If it's the right treatment, if the therapist knows the how to tailor the treatment, and also if the patient is really motivated to get better. With psychotherapy, the patient's motivation plays a big role, and it takes a lot of work to actually get better. It's not the same as just taking a pill, which also, I mean, requires remembering and sort of being diligent about it. But with psychotherapy, it's a lot of work because you have to come in for an hour. You have homework afterwards. You usually have to keep logs. You have to practice your breathing, practice this, practice that. Sometimes talk about things that are really difficult to talk about. So it requires motivation to actually get better. There's a joke: how many shrinks does it take to change a light bulb? Only one, but the light bulb has to want to change. And that's really sort of what it's like in therapy. You can't just have the therapist working. It's a partnership. Yeah.
Yeah.
So you've seen a lot of changes recently in the main treatments of epilepsy, or has it pretty well stayed the same?
No, I think that epilepsy is also sort of a renaissance, not just in terms of medications. We have also now medical marijuana, right? Which, just think about, I mean, a
Yeah,
few
how's
years
that?
back,
Is that working okay?
it seems to be, again, it's depending on the case.
Okay.
Yeah, but even for children, for some children who have really, really treatment-resistant epilepsies, they're doing really well.
Yeah, I've read
Charlotte's
about a
Web.
patient that the mother moved the child to Colorado because it was
Hmm.
legal to get marijuana.
Yeah, yeah,
Yeah.
Moved our whole
yeah,
family
yeah,
just to get
That,
yeah,
marijuana legally.
yeah,
CBD research. Yeah,
that's
a lot.
yeah,
yeah,
we got
yeah.
Charlotte's Web.
Have you heard of
Charlotte's
that,
Web,
dog?
exactly. Yeah, yeah,
Yeah.
yeah.
Charlotte's Web, yes. Yeah.
And now it's much more mainstream, and it actually, for some cases, it really is helpful. Then there's also diets, ketogenic diet, the modified Atkins diet, I think it's
I can,
called. Again, I'm not a nutritionist, but I just put it out there. I'm not a psychologist, but just from having worked for many years in the epilepsy program, so there are diets as well. I believe they're more used with children, partly because it's so hard to stay on those diets that if you're an adult, you're probably going to try to sneak something in. And a child, you're just sort of like, you give them what they need to
right.
eat, and that's it, right?
You
Yeah,
you prescribe that? Can you prescribe marijuana? For
I don't know.
you don't?
I'm a psychologist, so we have some neurologists who
Oh,
are
okay. Can they do it? Can they prescribe it? Is it
only
legally prescribable?
only if they're certified. They have to be
Oh,
certified. For
okay.
example, we work out in New Jersey, so they have to have a special certification
Oh, I see.
that permits them to prescribe marijuana. Yeah,
It's the
yeah,
same with OxyContin now. Yeah, it takes a lot of hoops to jump through if you want to prescribe a narcotic
mm,
for pain.
yeah,
It's
yeah,
a lot
Yeah.
different than it was a few years ago.
yeah.
It,
Well,
what's funny is North Carolina, you can't grow it, but you can take it.
okay.
Really,
I'm
There's
like,
a
it's a
law.
okay,
mystery where you
Yeah,
got it.
yeah, yeah.
right, right.
Uh,
That's just
I think
odd.
the
They
laws are
approved it.
catching up. Yeah, yeah.
Yeah.
Mm. You know, over time, right? They're going to catch up because they've got some of these these rules that don't make sense, right? But
Mhm.
definitely, yeah, medical marijuana, diet, the pacemaker that I mentioned, then addition, newer tests that are much more precise. All of that is coming, and then new medications, right? They're coming down the pipeline all the time.
Right.
So yeah, yeah.
Yeah,
One way they knew about the Klonopin helping me is I took, uh, well, the clobazam helping my seizures was the doctor told him when my dad passed away that I took Klonopin just for 2 weeks.
Mhm,
And I couldn't believe that I didn't have what I say a spell
mhm.
during that whole time where there was a lot of stress and having really to be there for my mom that
Yeah,
I didn't have one. So, and then when my husband passed away, I took it with them but during that time too,
yeah,
and I didn't have one.
yeah.
And I told the doctor, they said, well, after we do the other video EEG, and they tried now clobazam,
Mhm.
and I've been taking it. Now, I have to take the pediatric dose though, which is very weird.
Yeah, I mean, good. Um, yeah, I think sometimes patients are their best allies, right? Because you observe things, right? And you said, wow, I noticed that when I took this, for this one thing that happened, right? It seemed to help. And so then you had a good communication with your doctor, right? You're able to sort of bring this up and discuss
Yeah.
it. Yeah, yeah. Uh-huh. Yeah.
I know
Sometimes, like
some
I said,
websites would have questions already listed that you could fill out yourself. And people, I guess we need to really push patients to do that, to know what to ask their
mhm.
doctor and to be
Yeah,
able to tell them their symptoms. That way, they would also be able to tell if it's a really epilepsy or maybe go with non-epileptic.
mhm, mhm.
You know?
Yeah,
So
yeah, yes.
we need to know more about that. And
I think the more educated the patient is, the better. Because they know, if you understand, why you're doing what you're doing, it's way better. It's way easier for someone to be compliant with rather than just saying like take this, right, or do this.
hmm
To give some rationale for this is why we're doing this. It goes a long way. Or knowing what questions to ask, right? Come into the office with some solid questions that you want to have the answers to. And like I said, sometimes patients have brought up PNES to their neurologist of many years, and finally the neurologist has said, maybe we should do a video EEG on you, and lo and behold, they have PNES. Yeah, yeah. I think that's happening
so
more and more because of Google, Dr. Google and whatever.
well, Yeah, I read too that it could be 20 to 50% now of the patients that could be diagnosed. Is that correct?
With PNES.
PNS, and,
Well,
and
it's
was off of
uh,
their epilepsy meds and everything because of that. Is that?
the I would say it's a little, it's around, at least the last number I saw was around 30% of patients who are in an EMU, in an epilepsy monitoring unit. So they've, this is sort of like the highest level of testing. Once they reach that point, and again, this number could be, a little bigger or smaller, but around 30% are going to be diagnosed with PNES. And that's because PNES, it doesn't respond to medications. So these are patients who are having seizures. I guess they would be considered medically refractory. So at some point, they're going to hopefully, be sent for video EEG monitoring, and then they're going to have their typical seizures, hopefully again, because people don't always have their seizure when they're in the hospital, right? I mean, it's the bane of everyone's existence. But if they have their typical seizures and they get captured by EEG and with a camera, then they may end up with a diagnosis of PNES. Yeah. Mhm.
I would like to see a lot more of that early diagnosis, especially considering what the medicines do to the body over time,
Yeah.
which is not often discussed. But I know personally
Yes.
from my father, you can tell not only how they affect him daily. I mean, certainly some people need them, but if there could be some more understanding, whether a combination therapy or, as you were saying, early diagnosis,
Mhm.
really make a big difference.
Yeah. Yeah.
Yes.
On average, I don't know if this number is a little bit better now, but on average, it used to be 7.2 years from the time of the first seizure until the patient was correctly diagnosed with PNES. So you're right, Simon, that's 7.2 years of probably taking anti-seizure medication that is not helping,
Effective, yeah,
has side effects. Yeah,
yeah.
yeah,
That's
mhm,
great.
Wow,
yeah.
wow,
That's
yeah, yeah. To
good
give that
news. Yeah.
medication and have it useless, what a waste of time that was.
Yeah, yeah, yeah.
And
Uh,
money.
And money. Yeah, you're
yeah,
right.
yeah.
Roxanne.
It
Yeah.
must, what, were a lot of, did you know a lot of epileptics, Roxanne, that still were having seizures and still were taking Dilantin and had them?
Yes.
You know a lot of epileptics
Not
that
a
were
lot,
not
but
much,
yeah, not a lot with on Dilantin, but um,
a good number.
a good number, yeah.
Yeah.
But
Yeah,
a lot of other.
we were just not trained for that. It was just, oh no, they're not compliant. They're lying. Because
Mhm.
sometimes patients don't tell the truth, as you know.
True. Yes.
And some would insist, no, no, I took it, I took it. The mother would say, no, no, I
Yeah.
took it. And you believed them if the mom said it. I mean,
Mhm.
how many moms would lie? Not many.
Another generation.
Gosh, all the medications now, and then when I just started off with phenobarbital,
Yeah. Yes.
Is
and
that
Yeah.
still, I was going to ask that, is that still in common use, Roxanne or Lorna? Is that still in common use?
Not
mm,
Phenobarb?
common, but
not
it's still
as
used from time to
common
time. Yeah.
as
Yeah.
I've talked. Yeah.
If
Yeah.
they're allergic to Dilantin or something, they go to phenobarb.
There's a lot of medications out now, but definitely yes. I mean, people are still being prescribed. Again, I'm not an epileptologist, but from what I see, yes, there are patients still prescribed phenobarbital from time to time. Yeah, yeah, maybe more than from time to time. I'm not sure how much. Yeah.
So
The-
how do you work them off of the medication, be it be prescribed? Do you put them on like an anxiety pill and then work them off of their seizure medicine, or?
So yeah, that's a great question because yes, a lot of times they have been on these medications for a while. So we work as a team. The epileptologist is going to be the person who's going to make the decision, to take them off medication, because that's a tricky decision to make. You have to be pretty sure that the patient has PNES and doesn't have epilepsy, because otherwise it could be really dangerous, right, to take them off the medication. So typically the epileptologist will decide that, and then will take them off the medication. However, that medication needs to be,
Yeah, I
discontinued.
know on an emergency basis, Valium's the best. If you want to stop that seizure in the emergency room, I've never seen Valium fail.
Mhm.
And if it doesn't work, you give more. You give up to 10, 15, and it generally works. It stops the seizure, because sometimes it's not good for the patient to keep seizing. I mean,
No, yeah,
obviously, it's not
yeah,
good, so you got to do something. So
yes.
I found that Valium,
Mhm.
the benzos work very well.
Mhm. Mhm. Yeah,
Yeah,
yeah.
especially with the Dravet syndrome now, or if you say Dravet or Dravet, which
So they,
how
yeah,
how many different types they could have, one right after the other, and what to give them is
yes,
that's I know a mom with a
mhm,
daughter that has
Yeah.
it, and it breaks my heart some of the
yeah,
days and nights she has to go through, and what to give her child as to what
yeah,
their type of seizure they're having.
Uh,
yes, yeah.
They have the seizure all night, Roxanne.
Multiple a day, right? Yeah,
Yeah, multiple different
Wow.
types and all day, yeah. And
yeah.
she, oh, poor little
Do they
thing.
knock them out, the patient out? They knock them, they don't knock them out? Anesthesia?
She
No?
gets not knocked out really,
Yeah,
but she gets wore out
Yeah.
along with
right,
the medicine
right.
because I mean that's what really happens to her. She gets so wore out from
It can
having
be
that so many
fatal, right? It can
seizures.
be fatal, the status
Yeah. Oh,
epilepticus.
that's yeah.
Yeah.
Mm-hmm.
You've probably known people that have died
I
of
do,
status.
I have. Yeah.
You have
Yeah.
many. It's not rare then.
No. Well,
No.
not and then from SUDEP too.
Mhm.
It's knowing some people
Yeah, yeah,
from SUDEP.
yeah. Yeah, there's a few
Yeah.
foundations out there. I think that were created by parents, right, of
Yeah.
children who died from SUDEP. The Danny Did
Then.
Foundation, right? Yeah. And
Mm-hmm.
then Chelsea Hutchinson, I think, the Chelsea Hutchinson Foundation,
Yeah,
something
that
like
one
that.
too.
Yeah,
I forgot
yeah,
about that one, but yeah.
yeah, yeah. Um, yeah, it's terrible. And I think that one of the things that has changed now is that doctors are talking more about SUDEP, because they used to not mention it to not scare the family or the patient. But now, they are alerting, the family. And there's some mattress sensors and special pillows, and also, I guess, the sensors you can wear on your
Think about,
wrist.
huh?
Yeah, yeah. Which give a little bit more, more peace of mind. Yeah.
I think the science of EEGs. I don't know, haven't been following it, but I imagine that field must be improving in accuracy and I don't know. I'm just
Yeah.
guessing. I'm guessing so many things are being improved now
Mhm.
that the EEGs would somehow get better as far as
Yeah,
what they
you
were
would
supposed to
think
do.
so. Yeah.
And
One person with the Epilepsy Alliance
Uh-huh.
has helped with a portable EEG machine they could take home
The
and
ambulatory EEG.
yeah,
Yeah. Yeah.
uh-huh, and
Yeah.
have them that way.
Yes. Yeah.
So I don't know how that would help really to bring it on is have more, I don't know, be more anxious in at the
Mhm.
hospital and maybe have one, but
Yeah.
maybe not
Yeah.
the kind you have when you're at home. That's just
Yeah.
so much
Yeah.
to
yeah,
ask, so many
is it
questions.
universal that patients get an aura before they're having the seizure?
No, no, not always.
It's
It's
not
actually
universal.
it's the lucky ones who get an aura, because it allows you to get to safety, for example, or to know it's coming on, right? Rather than just, being taken by the seizure and maybe falling. Yeah, yeah. So,
Yeah, lucky. I say that I'm lucky that I have the aura and knowing when to put fork or knife down, unless my magnet picks it up.
It must be
Yeah.
hard also to find a competent epileptologist. I remember when I was rotating in Chicago as a med student, we had
Yeah.
a neurologist, a generalist, um, who would judge our decisions. So as med students, when you see patients, they ask us to suggest medications and to suggest treatment. This guy used to change like daily. And so we were made to feel stupid, but he was also trying to figure it out too. And then my attending was trying to second guess him. And I was like, well, all these different medications, which one is
Yeah.
right? And then the patient's wife would say, no, 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 you guys are all wrong. This is what this should be on. And I was thinking, wow, to be an expert in epilepsy must be a real find.
Yeah. Yeah. And
Well,
especially if you're being taught
I'm
that way,
that
right?
patient
Yeah, it's crazy.
Yeah.
because of knowing everything I've been on and what the side effects could do to me. Um, my doctor sort of knows ahead of time what to suggest, I guess, and that's good because the notes and everything, as times as I've seen her, she knows what I'm on,
Yeah.
and I know the side effects that I've even decreased it just by emailing her. And
Mhm.
she said, "Well,
Mhm.
just cut it in half."
Good. Yeah. Yeah.
That's good that people know more. Like you said, they Google read, I guess maybe,
Yeah.
but
Yeah. Yeah.
yeah.
Well, there's also the National Association of Epilepsy Centers, that you can look for an epilepsy center near you. So that's a good way to find an epileptologist. For example, you can just enter the zip code and it'll shoot out, I think, level 3, level 4 epilepsy centers, that sort of thing. You're lucky, Roxanne. You're in North Carolina. You've got some
Uh-huh.
really good, Wake Forest is excellent. But some people, are maybe in some places where there's less of that. And so they can, do the search and actually go to a place that is certified.
I get all kinds of questions from patients. I get it from Africa, and that's exactly one of the places you're talking about. They just don't have epileptologists. They have general practitioners. They're the ones
Yeah.
that handle them. And this one
Yeah.
particular patient wrote me, they had refractory seizures, or having seizures in spite of what the GP was giving them.
Mhm.
My advice was, look, I'm not practicing neurologist, neurosurgeon. However, I would recommend going to see an epileptologist, even though it may have to go to the capital city of
Mhm.
Uganda or
Yeah.
whatever country he's from,
Yeah.
because the general practitioners just have reached their level of
Mhm.
expertise,
Yeah.
and you need to really go to a specialist. The person was obviously very distressed. They didn't know
Yeah.
what to do.
Yeah.
There they are. They've seen doctors. The doctors aren't doing anything, but they're
Yeah.
still having seizures.
Mhm.
So I said, go to whatever you do, sell a cow or whatever, go to an epileptologist.
Yeah, yeah. No, it's true. I mean, that can make a big difference. Because like Simon was saying, there's just so many medications, and these are maybe good for this type of seizure, but not for that one, and this and the other. So it's possible. The same thing happens with South America. I'm from Argentina, and it's very, very hard sometimes to get a diagnosis of PNES because there aren't that many video EEG monitoring units.
Right, right.
So,
Yeah.
unless you're in the capital or whatever, like you said, like it usually tends to be in the capital. They have some of this, but not out in the rural areas. Yeah.
Well, curanderos, they take care of seizures, right? Really,
Yeah,
curanderos.
curanderos. Yeah, yeah.
Yeah, curandero is a Spanish doctor, not a doctor, a Spanish witchcraft person,
Yeah,
right?
witch doctor. Yeah, yeah, yeah,
Witchcraft,
yeah,
they'll treat epilepsy.
yeah, yeah. And PNES sometimes as well. Not always, sometimes it works for whatever reason, but obviously we would recommend that the
Placebo
person
effect, yeah.
see a neurologist, just to be sure, because there could be all sorts of things going on there. Yeah, even with PNES, a lot of times, if a patient gets diagnosed with PNES very quickly, it just, you want to make sure that they were diagnosed with video EEG monitoring, either in the hospital or ambulatory, like you were saying, Roxanne, and that they actually captured their episodes. Because sometimes someone will say, oh, well, this person has anxiety in their background, or they had trauma in their background, so they probably, this is what's going on. But you can make a mistake with a diagnosis if you haven't, really done your due diligence and captured the events and see that they're all non-epileptic and this and the other. Because there's also that 20% more or less who may have epilepsy as well, right? So you don't want to say like off all your medication, and now you go to the psychotherapist. You want to be really sure of what you're saying. Yeah.
Yeah,
Yeah.
that was me. Yeah,
Yeah.
because not knowing about them when he says, "Oh, you just have these," and I'm like, "No, it can't be." And well,
Yeah.
that people need to know that those are out there too. And it's
Yeah.
I laugh. Part of me with my epilepsy, I laugh about it and I say, "Tell them it's not all in their head."
Yeah. 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 and
That's how
and
I
it
deal with it.
like we said, it's a brain network disorder, right? I mean, it's much more than just because I think sometimes people hear this and they say, what are they saying, that I'm crazy, that I'm like a stressed, whatever, I can't handle stress. But it's much more than that. But it has to be explained to you correctly, not just sort of dismissed, like, oh, it's just psychological, off you go. Because that, of course, no one's going to take that diagnosis and accept it, right?
Oh
Seriously.
yeah.
Yeah.
It feels like a slap. It is a serious disorder. It can be treated, but it has to be presented to the patient in a way that they can actually sort of hear it, right? And take that. And for you, you weren't even sure that that was the case, and then it ended up not being. But even if someone does have PNES, if it's presented in a respectful way, and explaining, listen, this is what we know about how this develops, and this is what we know about risk factors, and this is what we know about why the treatment works. That goes a really long way than if you just say, see a shrink, you have a psychological issue, right? No one's going to accept that well, right? I
Yeah.
mean, it's
Yeah.
offensive. Yeah, yeah.
Yeah.
Yeah, that must be tough.
Well, tell us about your book. You've got a
Oh,
book.
yeah, yeah.
I want to
Yeah,
know
So I
how
have
did
put it
you.
two
on the
books.
screen. Put it on the screen.
Oh, let me see.
You
I
got
don't
a
know.
picture of it?
Um, I I don't think
Oh, that's
I'll have
okay.
to
Don't
look
worry
for it. I'll
about
have to search for it. So there's
I
two
think
books.
I
One
closed
is
it.
it. Is it in
Psychogenic
Amazon?
Non-Epileptic
Is it
Seizures.
in
Yeah, they're
Amazon?
both in Amazon. They're both in
Hmm.
Amazon. One is Psychogenic Non-Epileptic Seizures, a guide, and that was written over 10 years ago. It's for patients and their loved ones. And it is just meant to be, at that point, there was nothing online about PNES. And so out of frustration, I said, let me put everything on paper that I know at this point. And that way, patients, when they get this diagnosis and they get shoved out the door, at least they can get a book, that explains some of what's going on. So that book has been around for over 10 years. And there we go, screen sharing. Oh, there
There
it
you
is. Yeah,
go.
okay. So there's the book. Yeah, um, there it is. And that book is special also because all the royalties are donated to Epilepsy Alliance America.
Oh,
So
wonderful.
I don't make a cent off of it. It goes to their PNES scholarship. And every year we give out, I think it's 10 or 15 scholarships to students who have PNES and who are either in college or they are in trade school. So they are educating themselves in some way and they need that financial boost, that financial support. And so they can apply for that scholarship. Actually, April is the deadline. So if anyone is watching and they're thinking about this, Epilepsy Alliance America, you look up PNES scholarship, and that's where you get your application to download. And then the other book that I wrote was more recent, and I think it's the next one down there. It's a Psychogenic Non-Epileptic Seizures pocket
that's
book.
yours too, right?
That's mine too. That's a pocket book, and that's for clinicians. So that's for clinicians, because a lot of times I used to get emails from clinicians saying, I've just started working with this patient who has this thing called PNES, and I don't really know how to approach them. And so that book was everything. My co-author and I just sort of put everything on paper that we thought, these are all the questions we keep answering over and over and over and over. So let's just put it in a book. And that way, if someone has a question about how do I work with this patient, it's a little pocketbook, and you can just sort of flip through it, and it gives you most of the information that you're going to need. It's
Well,
got
thank
stuff
you.
like yeah. So that's the pocketbook for clinicians. And then there's a website that's called non-epileptic-seizures-education.com, and that's with little courses. So those are just little courses, 20 minutes long on different topics, and it's for clinicians.
What's the website for that? I'll get that.
Non-epileptic seizures education. I know it's a mouthful.
Okay.
Right. Well, she put it to the side.
Oh yeah, it's in the chat. Yeah. Yeah. So because that's a big part that's missing. We actually, I'm glad that you brought this up. Patients will often get diagnosed, but then they are sent out to look for CBT, let's say. And what ends up happening is that the CBT specialist may not necessarily know how to work with this disorder. So the pocketbook and the website, it's a different website. That's the general website. That's for information, the one you're showing, John.
Okay.
It's one that has education on the back of it. So it's non-epileptic seizures education.com.
The very first one.
Edu.
Educate. No, it's actually here in the chat.
Oh, okay. Let me get it.
Yeah. So that was a big issue as well, that clinicians who treat this were unsure of themselves. They didn't know how to treat it. They didn't know what it was. They would say, oh, but these are seizures. I don't think I should be treating this. And if they're non-epileptic seizures, that's the person who should be treating it, a psychotherapist. But someone who knows what PNES is, knows some of the tools that you typically use. Who's going to know what to do if a seizure happens in the office? It's not a rocket science, but it does require having some additional knowledge.
Right, here's the website, right?
Yeah, that's it. Yeah.
Do your courses?
Yep, it's got courses, for example, returning to school, working safely with PNES in your office. And some of the courses are free, some of the courses are not free. We're also offering supervision, that sort of thing, through that website.
Man, I wish I was a student again, right, dog? Don't you wish you were a student again? All this information is available.
Yeah.
Okay.
On
My
the damn smartphone.
Yeah.
Jesus Christ, man.
Well, I think Simon has been a student quite a bit, right?
Yeah, that's why he called me the dog, because I work like a dog.
Oh my gosh.
Yeah.
People ask
medicine.
me.
He's got to be
ask
the
me what
world's
books I
oldest
read.
neurosurgeon.
Well, they ask me what books do I read, and I say I read journals.
Yes. Yeah.
So that's just me. I don't read novels. I read journals.
Yeah. Well, I read some novels, but about epilepsy usually, because we have an epilepsy book club, and I love it. I love it because it gives me a chance to read a novel instead of reading just journals, right? But it's about epilepsy, so I still feel that I'm still working. And there have been some beautiful novels. We just read one. It's called She Danced with Lightning. Um, and it's about a dad writing about his daughter who had epilepsy.
Hmm.
And just, it's just fantastic to be able to read some of these books and in the person's own words, right? So this was a dad, writing about what his experience was like. And then we read some others that, it's a person who's writing about their epilepsy, or a brother writing about his brother who had epilepsy. Yeah.
I've interviewed two authors
Okay.
that have wrote, all about their seizures. And another thing, after talking to one of the writers from England, I have another friend from England who they were completely opposite with how they dealt with the government. So
Mhm.
it's, yeah,
Yeah.
it is very different with
The
their
files.
government, and then how they dealt with the two different ways of not being, they, England chooses what kind of job you have when you have epilepsy or any kind of disorder.
Really?
Oh,
And one of the people fought it, and
Yeah.
another person took what they chose for them.
Uh-huh.
So it's even different over there too.
Uh-huh.
So
okay,
I've
that's
met a
I'm
lot of
another
I'm from
issue.
England. I'm actually from England.
Are
So,
you
Simon,
Yeah.
good?
is your experience is that what or is it because maybe someone cannot drive, cannot be a bus driver or a chef or something like that?
What?
Uh,
I'm sorry.
in England, what Roxanne was saying, have you observed that you're not allowed, for example, to do certain jobs because you have
Yes.
epilepsy?
My dad wasn't allowed to drive,
Uh-huh.
but he drove anyway.
Oh,
He
okay.
was a race car driver.
Oh.
But yeah, that he lived in the country, so it was
Mhm.
nobody found out.
Yeah.
But yeah, England is quite a restrictive place.
Uh-huh. Yeah. Yeah.
Moved to America.
Uh-huh. Yeah.
Yeah.
The guy that actually fought what they said.
Uh-huh.
Can we get back to four people? I tried and you restricted me, John.
Oh, yes. Let's get back to just the four faces, right?
Yes.
Yeah.
Is he listening?
I'm not sure.
John.
John, can
Yeah,
you unshare again so we
I'm
can go back
sorry.
to the
I'm
panel?
on chair. Okay.
Yeah.
Unshare. Thank you.
For
Yeah.
some reason, I'm
There
restricted.
we
There
go.
we go. But
Yeah.
There.
anyway, the guy that fought being told what to do for his job, he can write music after he has a seizure.
Hmm.
Is that not
Interesting.
amazing?
Yeah.
Wow.
Yeah.
Mhm.
Wow. That
Yeah.
leads
So
to a lot of possibilities.
eh,
Mm-hmm. Mm-hmm.
he just wrote a new song and he sent it to me. So
Uh-huh.
He
I'm
didn't
thinking
have any
about
talent
asking him.
before. Wow, I think I've read about that. It was like,
Yeah.
yeah, he developed this aptitude all of a sudden after a
Yes.
seizure, right?
Yeah. Yeah.
And I interviewed him too anyway, but um
Interesting.
I'm gonna ask him if I could play some of his music at the
Yeah.
beginning and the end of the show.
Oh, that would be excellent. Yeah. Yeah.
Hmm.
Uh-huh.
Yeah.
Uh-huh.
It's a
Yeah.
good
So
idea.
I
Well,
can.
I've got to go, Lorna.
Me too.
I don't know if you want to finish up, Roxanne. Do you want to keep going, Roxanne, or you want to finish up?
well, it was really well, it's 5 o'clock. Yeah, we were gonna
Yeah.
do an hour. So
Yeah.
Yeah,
thank y'all for
yeah.
joining. This was
Well, thank
nice. I
you
Thank
appreciate
for
you.
it.
Nice to meet
setting this
all of
up
you.
and running this. Yeah, yeah, it's
Yeah.
been a pleasure meeting you, Simon,
Nice
John,
meeting you. Yeah.
Roxanne. I feel I know you, Roxanne, because we're friends on LinkedIn. But it's really nice to see you. Yeah,
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 help
Yeah, it was
Roxanne
nice to
get
have.
this off the ground.
Well, I
yeah.
Okay,
actually speak
we
to a
look forward
doctor
to hearing.
Friday, a
Okay.
pediatric neurologist Friday. So
So
I'm
Okay,
Roxanne,
gonna
maybe I'll send you some
just
names of people who I
oh,
think
that would be
you
great.
might
Thank you.
want to reach out to. Okay. Yeah. I wish you the
Thank you.
best with this.
I know. Yeah,
And
thank
maybe
you.
I'll see you again, right?
Thank
I'll
you.
see you maybe at
yeah,
AES.
Right.
I try to tell Roxanne, don't be afraid to ask people. They'll do it. They'll
Yeah,
do it.
yeah,
They like to do it. So,
exactly.
and I appreciate you coming.
Yeah.
Well,
Thank you.
okay,
Thank you.
everybody.
Bye
Thank
bye.
you.
All
Until
right.
next
Bye.
time.
Bye,
Bye
Roxanne. Bye,
bye.
Simon.
Bye.
Bye.